So today we're just talking about the Health Worker Registry. And we'll just kind of do a quick overview, talk about some of the main features, then we'll get into the standards, then what technologies are out there, and then we'll talk about some implementations that are out there. So the Health Worker Registry is, it's just a place where you have all your health workers in one place so that people can find out who they are, where they are, and kind of what their capabilities are, what licensing or training they've had, so that, in a crisis situation, you can look up people to find out where you can send, if you can send people to an Ebola outbreak, who have had the training or who needs new training and things like that. So on the architecture diagram, it's the Health Worker Registry is one of the main component layers, although I know we're talking about kind of redoing this diagram. This is sort of the current one and where the Health Worker Registry fits. So the main features, it's where you would, ideally you want to have all the health workers in a country, including the public and the private sector. Although sometimes collecting the private sector is a little more difficult to get current information, but luckily with the licensing you can generally get a pretty broad picture. You want to maintain a minimum data set of information. The WHO has published one. We'll make sure these slides are shared so that, because there's links to a few of these things, so you can look at what the WHO has published for a minimum data set, but generally that'll be customized depending on the country context. Usually it will receive updates from lots of other systems. There may be the public HR, there could be many private HR systems, licensing councils, and again, there could be other things that are out there that might be feeding your health worker registry. And the main thing is that it can then respond to queries across all that data in one combined set. Some of the use cases around where you would use one, your patient management software would want to, you can pull information from the health worker registry, so you don't have to, set it up in each individual case. Disease surveillance would have them, again, as I mentioned before, if you've got an Ebola outbreak or just tracking what's going on out there. The payroll system could pull from it to make sure people are, things match up. And again, obviously the main HR, again, can kind of validate its information of what's there. So some of the main standards that are out there around this are published by IHE. There's the Healthcare Provider Directory, which is HPD. It only tracks providers and organizations, and this is based on LDAP. I think this has been used in a couple places in the US, but I don't think it's gotten a huge adoption. There's Care Services Discovery. It also adds in the ability to track facilities and services, so that you have one place where you can see where people are and what services they provide. This is based on XML and XQuery. It's a BaseX server is what we have done to support that. And then Mobile Care Service Discovery tracks locations a little bit separately from facilities, and it's based on FHIR release 4. So in CSD here are how the various pieces link together. Again, a provider can provide a service, usually linked to an organization that's providing that service that the provider works for. A provider can be at a facility, and the provider can have multiple organizations, multiple facilities, and multiple services. Then the organizations are kind of how the hierarchies are managed, and a facility can be again linked to multiple organizations. mCSD is a little bit different. Sorry if this one's a little hard to read. It may be a little bit easier in the mCSD specification. But it kind of, again, adds that location as a separate piece, so you can maintain a jurisdiction hierarchy as well as different organizational hierarchies if you need to manage multiple ones. But otherwise, it's very similar. I mean, these were obviously based on the same starting point. It's just how it ties into the underlying, mCSD, since it's based on FHIR, has a little bit of a difference there. Again, CSD and mCSD are very, very similar, but in the, just going with the latest one for now, there are two transactions in mCSD. The first one is to do queries on the information. So the specification kind of spells out what you can search on and how you can get the data. I won't go into the specifics there unless someone has any particular questions, but ultimately it's just how, in all the systems can kind of query what's out there. The other transaction is, where all of the systems that have information would implement this one, and it's just where they can send all of their updates to the Health Worker Registry. So if you've got an HR system out there, it can send all its updates as changes happen to the registry, or the licensing systems can do the same. And again, CSD has a very similar model to this. So, I mean, again, this could work in anything, but just to show a kind of a very complicated example of how, a deployment where you might have lots of systems out there, and also where you might be trying to tie your information into a global system, so you could have a country server that gets updates from the various local servers. So you could have your HR systems, the private, could feed to that. You could have a client out there that's maybe looking up licensing on a mobile app, and it can query that country server. But then you may also be feeding a global system that can pull the updates from there, and then you can have partners and global clients that are then querying that to find out what information is stored in this system. And again, a lot of times this is the sort of the most complex example. Generally, it'll be a little bit more simpler. So the technologies that we've built, or that we're familiar with, CSD has been out a few years longer, since FHIR is relatively new. There's software called OpenInfoman. Again, as I mentioned before, it's built on BaseX, which is an XML database, and then it uses xQuery to look up information, and you can kind of define endpoints that can then return the data you want to see. And mCSD is built on FHIR. Jimby has written a FHIR server called Hearth, based on Node.js and MongoDB. I'll get into more information about that in a minute. And then FHIR is the reference implementation for FHIR, so it's usually kind of on the cutting edge. It's built in Java, and you can use multiple database engines behind it. And then ultimately, any FHIR server that supports the required query parameters can be built to support mCSD. Just to get a little bit of the implementations that we've done. OpenInfoman is used in the Datum project, mainly for synchronizing sites from the various country systems into the global system, so that when they report data, they know which sites are the same. It's also been used as a part of mHIRO, so that you can again have all the health workers in one place, and then use that to notify and to have SMS workflows to communicate with them. It was also used in BID Tanzania to, again, kind of synchronize the sites that are out there. IRIS is our HR management software, and it can, again, send updates to a CSD server using that standard. For mCSD, again, as I mentioned, there's Hearth. That's what we had used a couple years ago when mCSD came out to test at the IHE Connectathon. We've used it in the Gopher facility reconciliation tool. This is, again, something that's been used with Datum, but we're also implementing it in a few pilot countries to take your multiple facility lists and reconcile them to find out which ones match, so that you can compare if you've got a match facility list and DHIS2, or again, you've got IRIS and DHIS2, and you want to make sure that the IDs match up. You can go through this tool and kind of get the automatic matches, and then do any manual matching that needs to happen. There's also been a prototype set up in Uganda, although this hasn't been institutionalized, but just as kind of a proof of concept to show where it can pull data from the various systems and, again, have it in one place. As well, IRIS can, in the Uganda prototype, most of their systems are using IRIS, so it uses the kind of the mCSD piece to share their data. And then in South Africa, again, they've been developing a prototype for an HRH registry, and that one's using FHIR. I'll show a little bit more. This is kind of their whole architecture with how the Health Worker Registry kind of fits together. So on the far left side, we've got all of the various systems that will be feeding the health worker data. So there's their HR system, which is called PERSOL. There's the various councils, the medical council, the nursing council, and the pharmacy council are kind of the main ones they're starting with. They also have an intern and community service program where they already have some data, so that can also feed in. And then it could just be in any other private hospital system, anything else out there that has HR data. Since this is kind of in the early stages, the way to collect data from all those systems is going to be quite varied. So there's sort of a staging area where that data can be cleaned up, because some systems are in different states. Some of them have a good database system, some of them have paper systems, or just not just not very good systems. So there's some manual processing to get that cleaned up, and then the clean data can be fed back to them. But in the long term, it would be more automatic, where again it kind of goes through this interoperability or the mediator layer, which in this case they have OpenHIE. That way it can kind of accept the data, make sure that the permissions are set right, that they're allowed to do this. And then again, we've got the FHIR server set up there to where it can accept the data. They also have kind of a data warehouse for analytics, so that's where their aggregate data comes in. This is a DHIS2 server, so the FHIR server can, an operation can be done to aggregate the data, and it goes into their data warehouse so that they can do all the analytics. And then they've got kind of a portal, is that endpoint where people would be accessing the system, so that everyone comes into one place. So this can be for public or for private access. So public users can come in and they can do searches on the Health Worker Registry, so they can find out, if there's a doctor, a clinic near them, they can find the doctor that's there. They can make sure that doctor's licensed and that everything is okay with going there, or they can report if there's any issues. But they can look up to find people that are near them and see what their, the public level information will be returned back to them. But then also people from the ministry can log in, and then they can do more, larger queries. They can get back more information so that they can get, full lists of the health worker. But also, again, through that same interface, they could get reports, so they can see aggregate numbers on maps and things like that, so they can see where all the health workers are or where they might be lacking. And that warehouse will also be pulling in data from other places, so it could have population data, and it could also maybe pull in some pipeline information from the schools to see where new health workers are going to be coming in.